women. Testosterone is the hormone that makes men men. So estrogen and progesterone receptors have been found to be predictive about how a patient will do, prognostic rather, and also predictive as to whether or not they respond to certain drugs that are related to estrogen and having the receptors or not. So when you go for the extra tests, you will be tested for estrogen, you will be tested for progesterone, and you will also be tested for what is called the HER2/neu, where now it has been found that people with a certain mutation will express this in one of their genes. We can pick it up on the slide where your tissue is. This HER2 is going to be important because women who are positive, if they don't get the right treatment, tend to do worse. But the good news is that women who are positive will respond to a specific drug that's targeted at this mutation. And that drug is called Herceptin. It's targeted at this HER2/neu. What about these estrogen and progesterone receptors? Estrogen receptor positive tumors respond to a drug called tamoxifen, which is generally available, but some people may not afford it. And there is a big initiative by Cancer Serve Trust to try to get tamoxifen access to women who are marginalized and would not otherwise afford it. 75% of tumors that express the estrogen receptor will respond. So that's very, very good news. And that's how important it is to go ahead and get that test. For those who are medical, who are on the platform, you might just want to know this, that you can actually now classify breast cancer molecularly depending on whether or not it's ER or PR positive. If it's ER, PR positive and HER2 negative, that's the best prognostic type. It's called luminal A. If it's ER, PR positive, but also HER2 positive, it's a triple positive, and that's luminal B. If it's negative for all of them, ER, PR, HER2 negative, is called a triple negative tumor, and that probably has the worst prognosis in the absence of Herceptin. With the HER2, ER, PR negative, and HER2, it also has a not so good prognosis, but the good news from that one is that you can have Herceptin if it's available. So what is the role of pathology in all this? You can understand going to a radiologist and getting the pictures that show the tumor. You can understand going to a surgeon who removes the tumor. You can understand an oncologist who then determines whether or not you have to have it removed surgically, whether you need chemotherapy and or radiotherapy. Some women just need chemo, some just need radiotherapy, some need the chemo and or the radiotherapy before the surgery, that is called neoadjuvant, or after the surgery has been done and the team just wants to be absolutely sure that you've got all the cancer cells, because cancer cells are so small that sometimes you can't even see them on the microscope. To be sure that you've got it all, they might want to give radiotherapy to the bed where the tumor has been removed. So what is the role of pathology? The role of pathology is to determine the risk. For example, doing a BRCA mutation is to make the diagnosis, as we said, no meet, no treat, to provide prognostic factors like the size, the type, whether it's in vessels or not. Then also to give predictive factors like whether it's HER2 positive or ER or PR positive. And then, of course, to determine also to work with the oncologist to determine the staging. Staging includes things like whether or not it's in lymph nodes, and you will only know for sure if it's in the lymph nodes when you have a pathology report. And I just like to end with a small little case that should be, for those who are medical, they will understand it more, but even people who are not medical, you'll be able to see the importance of having pathology. So this is a picture on the right-hand side, a photograph of a 62-year-old woman who presented to breast surgery clinic because I think she must have passed through her local clinic. She must have been passed through her GP and showed them what was happening to her breast, particularly the skin of her breast and nipple. And they referred her on to a breast surgery clinic. The nipple had become hard. It was stiff. And on mammography and ultrasonography, they couldn't really find anything, but definitely the skin had changed, the nipple had changed, and she had this black, you see that arrow, this black flat patch or macule that measured 5 millimeters. So what was the diagnosis? Was it mastitis or inflammation of the breast? Was it fat necrosis? We know that sometimes women, for example, if you're involved in a road traffic accident and you're wearing a seatbelt, for example, the seatbelt can apply a lot of pressure onto the breast, and breast tissue is 90% fat. So the fat then dies and can become quite hard. Was this black change a skin cancer? Because breast is covered by skin. Was this black patch a skin cancer? Was it a breast carcinoma, or was it just a benign skin lesion, sometimes referred to as beauty spots? Women sometimes have got black lesions all over the skin, and that is just a benign skin tumor. What was it? Well, people could just assume, because it's new, because the nipple has gotten hard, and because there's this crusting, it must be breast cancer. So she went and she had a mammogram, and the mammogram shows, you can see on the right-hand side, that there's something unusual. So something unusual, but what is it? This is the left breast. That's how the breast should look. There's something going on the right side. And then the team was vigilant enough, and they decided to have a biopsy. And the biopsy just showed that this was a lot of fat that had died and become infected. And she just had fat necrosis. She didn't have breast cancer. She didn't even have a benign tumor. It was just fat necrosis. But if people had just misinterpreted the mammogram or misinterpreted the findings and just gone straight to have the breast removed, it would have been an absolute disaster. So the take-home message is that tissue, a piece of tissue, is the issue, because the tissue is what will tell and inform the team of doctors, clinicians looking after the patient, whether or not it is in fact cancer. So this is where the presentation ends. We've talked about why it's important to detect the lump early, how to detect it, seeing and feeling. We can do that on our own. And then we've talked about when something is found and we end up having a biopsy and it goes to a pathologist, what should we look for? I just want to end before I give my thanks to the presenters with a story that I tell people all the time. You are responsible for your own health, and you are responsible for your own breasts. And I also give this talk sometimes to men's organizations or to mixed audiences where men and women are both on the platform. And for people who are fortunate enough to have a partner, particularly a husband, it is the husband's responsibility to pick up these lumps and skin changes. I once went to a funeral, and there was a lineup to pass condolences to the widower, the husband who had lost his wife to breast cancer. And it is quite common in African culture, when you go to pay your condolences, you shake hands, bata maoko, and people always feel inclined, I guess for lack of better words, they feel inclined to ask the bereaved, what happened? What happened? As if that will change anything, or as if that will bring any solace. But in this particular funeral, people were coming, and it was pre-COVID, so there was a lineup, and people were shaking the hands of the bereaved widower and asking what happened. And then this man says, the doctors discovered late that my wife had breast cancer. So he's now blaming doctors who are at home, many of whom are females. They have their own breast cancers, their own breasts to worry about. And in fact, I didn't mention that, I mentioned that 1% of breast cancers are in males, but males can also get breast cancer. So the examination should be both of males and of females. So these doctors are looking after their own breasts. They're at home. He's there with his wife, and he's waiting for a doctor somewhere to discover that his wife has got a lump in her breast to the extent that it has ulcerated, it had spread to the liver and the bones. So we are responsible for our own health. And if we are in a relationship, if we are husbands and we are wives, we are responsible for each other. We are our brother's keeper. So I think I'll end there, and we still have enough time for questions. If I can hand over to Tatenda, and thank you very much for the opportunity to share. Tatenda, over to you.
Thank you very much, Professor. This was quite insightful. I have personally picked a lot out of this, and I am, for one, who's going to start examining myself every time. And yes, on that note, I guess we should buddy up, like what Professor was saying, because no one should fight cancer alone. It's our responsibility. I think even with my team, I'm going to start reminding them that, guys, have you checked yourself this month? Have you done this? Because it's everybody's responsibility. And without further ado, I'm going to leave this time to the founder of the organization, Miss Olive Thomas, so that she can just give her remarks and take us through the next stage. And you can send through your questions as Olive just does what she does. You can just be sending through your questions on the chat, and then we can answer them when she has given her remarks. Ms. Thomas?
Oh, thank you, Tatenda. I don't even know where to start from, but let me start by thanking everyone who participated in this speaker series. We didn't know how to structure it properly, but we thank God that it has worked. And thank you so much for sparing your time to participate and be with us here. And also like to thank the chair, Mr. invited, and he welcomed all of us very much. And a big and awesome thank you to our guest speaker. Wow, she's a phenomenal woman, perfect. Firstly, getting to found, we really want to thank you, Prof, for a lot that you could have been doing right now. You could have easily said no, but you said yes to our invitation, and we really, really, really appreciate. And to everybody else, I took two take-home messages. Know it before it knows you, and when you've known it, know it, not it. So that are quite two take-home away messages that I got, and I just want to encourage everyone who is here that we have learned. This was quite an hour, very informative. We also need to encourage others and spread the word that we've got in here, and basically just power. Prof has shared with us so much knowledge, and they also going to say kindness is contagious. We can also share the kindness with others by spreading the information, disseminating what we have learned today. And I really, really, really would like to appreciate. They were put in a chat box. You are free and we can take questions. I'll start. My question, Prof, would be, you mentioned about lumps and having to differentiate that leads to cancer or that shows cancer. So say there is a woman who is breastfeeding and she feels a lump. Can she find a lump? And also, if there's a woman who is undergoing treatment of breast cancer, are they also allowed to breastfeed during that time?
Okay, it was breaking up a little bit, but I heard that there were two questions. One was, the last one was if there's a woman who is breastfeeding and she's